Hi, this is Mike Kelly, and welcome to another chat on NorthJersey.com, sponsored by The Record, NorthJersey.com, and the USA Today Network. I'm joined this morning by my colleague Lindy Washburn, The Record's chief medical writer, and Dr. Adam Jarrett, the chief medical officer for Holy Name Medical Center in Teaneck, New Jersey, which is about 5 miles from New York City. And as many of you know, Teaneck, and North Jersey for that matter, is at the epicenter of the COVID-19 pandemic, along with New York itself. This morning, I'd like to invite you to submit questions to Dr. Jarrett through your Facebook Live link. Good morning, Dr. Jarrett. How are you?
Good morning, Mike. Good morning, Lindy. Good. Thank you.
Because there's been so much news lately, I'd like to turn over the first few questions to my colleague, Lindy. Lindy, go ahead.
Hi, Dr. Jarrett. I'm really interested in knowing where you think North Jersey stands now in terms of the coronavirus cases. Have we turned a corner? Has this surge crested yet?
I think we have, and it's not just here at Holy Name, it's the other hospitals. I think we're all talking about the fact that we believe we've come off the plateau a little bit. I do think it's important for people to keep in mind that the rise to the plateau was a challenge, and so therefore the coming down off the plateau is going to continue to be a challenge. Just because we peaked and come down does not mean that there are still not an awful lot of sick people in the hospital. We still have an awful lot of critically ill patients. We're still seeing patients in our emergency room. Unfortunately, people are going to continue to become infected, but the numbers have peaked to the best of our knowledge. And as long as we continue to follow social distancing, and as long as we are careful when we come off of social distancing in terms of how we do it, we should be through the worst part of this. Now, there are some concerns that we might see second and even third peaks. And I think that is why it's so important to come off social distancing in such a controlled, careful way, because until we have a vaccine, we are going to continue to be talking about coronavirus and dealing with coronavirus.
Now, what has been the impact on your hospital and the other hospitals in North Jersey from the crisis that's been unfolding at the nursing homes?
So the nursing homes have been really terrific about trying to maintain their population whenever possible in their facilities, which was really crucial in terms of the hospitals not becoming inundated, being able to take care of the patient population that we saw. So we saw some nursing home patients, all the hospitals did, but we never saw the kind of surge that we were concerned about seeing. And we still hope that we won't see that kind of surge, because the nursing homes have done a really good job at doing the best they can to manage their patient population at the facilities.
Okay. I know that you had talked about how the emergency room, the emergency department was being affected by people needing tests, and you'd set up tests outside, and you'd also expanded the capacity of the hospital with more beds for critical care patients, just a heroic effort on the part of your buildings people. Can you tell us on the ground at Holy Name now how things are now compared to where they were a couple of weeks ago?
Sure. And again, just because we likely have crested and come down off the peak, it does not mean that operations are back to normal here at the hospital. So we were doing outpatient testing in a tent outside the emergency room. We continue to do that, but the volume, which was well over 100 patients a day, is now in the 60 to 70 patients a day. Our emergency room, which was full with about 3/4 of coronavirus patients, now has about half as many coronavirus patients. So we still have an emergency room that is very much divided by coronavirus and non-coronavirus patients. So we still have all those negative pressure rooms that we are treating coronavirus patients in. So we're still busy. We have not yet seen, and I don't think we're going to for the next several weeks, we have not seen a return to normalcy in terms of non-coronavirus patients. Patients appropriately are trying to manage their issues at home when it's not coronavirus related, or even when it is coronavirus related and it is mild symptoms. Throughout the rest of the hospital, we have quadrupled our ICU capacity. So we have 4 times as many ICU beds as we had before this all started. I would say about half of those ICU beds are in use at this point. At one point, there were about 3/4 of those ICU beds in use. So we never reached a capacity that was beyond what we built, which is good news. We still have over 180 patients in the hospital with coronavirus, however. We peaked at around 245 patients. Today's going to be an interesting day for all hospitals in the Northeast. Mondays are notoriously busy days in emergency rooms. last Monday, although we thought we had begun to see the plateau, we saw a small surge last Monday, and then the rest of the week calmed down quite a bit. Hopefully this Monday we will not see that surge, but I do think we're going to see more patients today than we do every day throughout the rest of the week, because patients tend to come to the hospital more on Mondays. So today will be an important day to see whether we see a small surge, or hopefully not a large surge, or whether we continue the slightly downward trend that we've been on. I do believe that we're going to be dealing with large numbers of coronavirus patients, at least for the next 2 to 4 weeks. And I do believe that we're going to be dealing with coronavirus patients in general for the next year or more. I do hope that people understand the importance of social distancing so we do not have further peaks, although I am very concerned that we could have them.
Yeah, Dr. Jarrett, that's an interesting point you raised about the social distancing. Over the weekend and at the latter part of last week, we saw a number of protests taking place around the country by people who want to get back to what they would call normal life. What's your thought on that? I mean, you're looking at this obviously from the front lines of a hospital. What is your thought on watching these protests?
So I understand why people want to go back to normal, but the reality is that we can't go back to normal yet. There are too many lives at risk if we go back to normal. There is no doubt that for this disease, if you have access to healthcare, it can save your life. And if we go back to normal and the hospitals throughout the country, and particularly in the Northeast where we saw the largest surge, get overwhelmed, there will be patients who die because they don't have access to the care that can absolutely save their lives when they have coronavirus. So I think it's very important that people continue to follow the social distancing rules. I think there's a real chance that we're going to see some small peaks again. Hopefully, though, low enough that we don't go beyond what the hospital systems can handle. It is expected as we go away from social distancing, hopefully in a very controlled way, making small changes in what we do on a day-to-day basis, and then watching for several weeks. And if we don't see a surge, making another small change, and then watching for several weeks. And then again, if we don't see a surge, making another small change and watching for several weeks. If we do that, then there's a very good chance that we won't have further peaks. If we do not do that, there is absolutely no doubt in my mind that we can see another peak, and in fact, even a peak that is larger than the initial peak. If you look back at the flu pandemic of the early 1900s, in many places around the world, the second peak was higher than the first peak, and many more people died during the second peak of the flu pandemic than during the first week of the first surge of the flu pandemic. This disease, although not like the flu in terms of how it impacts people, is very much like that 1900s pandemic. You had a brand new disease that people were not vaccinated against, and the only treatment they had for it at the time was social distancing. And when they social distanced well, they saw smaller peaks. When they did not social distance well, or when they gave up on social distancing too soon, the second and third peaks in many places were higher than the first peak. We've lost over 40,000 Americans already, and I think those numbers are very low compared to the real numbers. I hate to say that, but I think that we're going to see much larger numbers because there are many patients who have been ill with coronavirus who have not been tested. There are patients who've died with coronavirus who have not been tested. So the 40,000 number that you're seeing that are being reported are probably low compared to the reality of this disease. And I wouldn't be surprised if the numbers are even as high as double of those numbers if we could do across the board testing, if we had access to that. And if we don't do social distancing, the kind of death that we could see on a second or third peak could be even more tragic than that.
You know, it's interesting. We have a question here from a viewer who asks, and along those lines, if you've recovered from coronavirus, can you get reinfected? Are you seeing anything from your perspective that could give a conclusive answer one way or the other?
So unfortunately, we don't know the definitive answer to that question. There is a general thought that there is at least some level of immunity after you've been after you've had coronavirus, but we just don't know that answer yet. The only way we're going to know that answer is when we start doing antibody testing, which we have actually begun to do at Holy Name this week. We're doing antibody testing in-house this week, and we're hoping to make that more widely available to the public over the next several weeks. The problem even with that testing, however, is we're not going to know if you test positive for that antibody and it's a low level of positivity, is that going to be the same as someone who tests positive and has a high level of positivity? I think that we all need to assume that we are potentially infectious even after you've had coronavirus for the time being. I think in several months, we're going to have better answer to those questions when we've been able to do antibody testing, when we're able to see whether patients are becoming reinfected. We're not seeing that yet, but I would not be surprised if patients who've had mild disease or patients who even had asymptomatic disease are can potentially get infected again. And that is why the antibody testing is so important. And that is why even when we start to ease up on the social distancing rules, even if you've been infected before, you should not assume that you're not potentially contagious, that you can't potentially pass this on or get reinfected. And we're not going to know the answer to that for quite some time.
We have another question from a viewer. Is there any word yet on possible medication for this? Are you seeing anything from your perspective on this?
We are seeing some things. There's about a half a dozen different medications that we're using to treat coronavirus. In the early part of the disease, we're using the anti-malarial medications that you may have heard of, hydroxychloroquine. We also started a study here using a medicine called ivermectin. We're not sure whether those medicines work, and there were some recent studies that suggest that those medicines do have some significant risks. And so when you use them, you absolutely need to use them with your physician or your nurse practitioner to decide whether the benefits of that medicine outweigh the risks. And because we don't know whether those medicines work, you have to use them very carefully. In patients who are getting more sick, we're using 3 different types of treatment here at Holy Name, and around the country, there are really 3 different types of medicines that people are using. The medicine that we are most optimistic about is a medicine called an IL-6 blocker. IL-6, interleukin 6, is a chemical in our body that promotes inflammation. You need that chemical in your body. It's an important chemical to have in your body. But if it's overactive, which is what happens when you're infected with coronavirus, it creates tremendous problems in your lung. We also think that it may be creating problems in your heart and in your kidneys and maybe even in your blood vessels as well. And we are seeing that these medicines that block that interleukin 6, if given at the right time, seems to have a significant clinical impact. We are seeing patients who are having significantly lower fever, who are having significant decrease in oxygen needs. And many of the patients that we've been able to successfully treat in our ICU have been treated with these IL-6 blockers. So that's encouraging.
Fascinating.
Excuse me?
Go ahead. I was going to ask though, this is very interesting to me, but are you in touch? I'm interested in it sounds like you're doing some interesting experiments at Holy Name, but from a national perspective, how is this organized? I mean, to me, it's interesting that, say, a hospital such as Holy Name is doing some work, and I'm sure there are other hospitals that are doing some work as well. But is there a network by which you can share this information so that from a national perspective, or even a statewide perspective, that we could get some kind of protocol in knowing how to treat people?
Yeah, that's a terrific question. So one of the IL-6 drugs that we are giving as part of a study. That study is through the drug company who makes the medication called Regeneron. And when patients qualify for that study, they are getting that medicine, and that study is available throughout the country. It is very likely that at some point in the near future, there'll be information about the results of that study, and we'll have a better idea as to whether or not that medicine truly worked. And it's studies like that that are really going to help us decide whether a medicine like these IL-6 blockers really work. Not all patients, however, are eligible for those studies, and these IL-6 blockers are available to be used for problems like rheumatoid arthritis. And because we see promise with them, we want to make sure that patients who are not eligible for them through the study are still being offered those medicines. And so we use a different IL-6 blocker in an off-label way, which is a perfectly acceptable way to use a medicine. Doctors do it all the time. Unfortunately, by doing it that way, you don't get the same type of conclusion that you get when you use the medicine in a study way, but in a way that's being studied. But on the other hand, we want to make sure that every single patient has an opportunity to get one of those IL-6 blockers. And hopefully the number of patients being enrolled in that study will allow us to draw conclusions about IL-6 blockers. The same thing can be said for another medicine called remdesivir. Remdesivir is an antiviral medicine that was used unsuccessfully for Ebola and unsuccessfully for HIV. We do believe that when given in the right patient population, remdesivir is also an effective medication. And I believe there are studies on the remdesivir, like the IL-6 blockers, that will let us draw conclusions in terms of whether or not it should be a standard part of the treatment for use in patients with coronavirus.
Interesting one.
Dr. Jarrett, we've heard a lot about the concerns about ventilators and a potential shortage of ventilators and policies about their use. I was wondering, for people who have not experienced this or might be sick at home, could you just explain what is involved in ventilator use and intubation, and what kinds of considerations patients might want to have, things they've thought about before they go to the hospital?
Absolutely. Well, first of all, the ventilator supply issue at this point, I think across the country, we're in a much better place than we were several weeks ago for several reasons. One, because we did such good social distancing that the number of ventilators that we thought we were going to need were not needed. Another reason why we need to stress the importance of social distancing in case there is a second peak, which would put us in a very difficult situation with ventilators. So let's talk about what a ventilator is. A ventilator is really a very last resort, almost heroic measure that is used for patients. So a ventilator requires that a tube is placed in a person's mouth and down into their throat to allow the ventilator to be attached to that tube, so the ventilator can essentially breathe for the patient. The ventilator essentially takes over the normal respiratory capacity. We set the ventilator for a certain level of oxygen. We set the ventilator for a certain amount of volume. We set the ventilator for a certain amount of pressure. And depending on the patient's size, depending on the patient's underlying lung condition and other underlying conditions, the ventilator is adjusted to try to make it as physiologic as possible. So it's as if the patient is not on a ventilator, but they are on a ventilator. And the ventilator is a very unpleasant experience. You have this tube down your throat that is essentially breathing for you, and it is very unpleasant. The vast majority of patients who go on ventilators need to be sedated and even paralyzed, because the ventilator takes over the breathing. And if the patient is not paralyzed, the patient's normal respiratory muscles buck and fight against what the ventilator is trying to do. So in the vast majority of patients on ventilators, especially with coronavirus, they are not only sedated, but they are paralyzed. And then unfortunately, the ventilator puts you at all sorts of other types of risks. You're lying in bed and you can't be mobilized. One, because you're on the ventilator. Two, because you're very likely paralyzed. And lying in bed for long periods of time puts you at all sorts of risks. It puts you at risk for developing bed sores. It puts you at risk for developing blood clots. It puts you at risk for developing other types of pneumonia. And so being on a ventilator is a very high risk, unpleasant experience. And to be very frank, all Americans, all people should look at their underlying condition, their age, their brain function, their underlying lung capacity, their underlying heart capacity, their underlying liver capacity, and they should make a very educated decision with their family doctor about whether a ventilator makes sense. Because for many patients, a ventilator just doesn't make sense, because the trauma from the ventilator is so big that many patients, if they go on a ventilator, their likelihood of surviving off of that ventilator is very, very low. And so this is why it's extremely important that all patients have this conversation with their family, with their doctors, and are talking about the fact that if something were to happen to them, whether it's coronavirus, whether it's a stroke, whether it's a heart attack, whether or not they'd want to put their body through the trauma of being on a ventilator and what the likely result of being on a ventilator would be. Many patients who go on ventilators just can't get off them. And unfortunately, it's a terrible way to pass. And so it's important that patients and their families and their doctors talk about this before they're on a ventilator, so good decisions can be made. I know an awful lot of patients who do not want to be on ventilators and make that decision ahead of time. And in many cases, putting a patient on a ventilator can be absolutely not the right thing to do, considering the patient's underlying condition. And that is why we need to. Go ahead, Mike.
Fascinating point you make there. I mean, this is a whole new world of bioethics that we are entering in, isn't it?
It is, and it's important that people are having these conversations. I believe, look, we have to face a reality. We're all going to die, right? It's just the reality of you're born and you die. And I think there's one other thing like taxes that you have to do, right? You know those are the three things that are going to have to happen to you. And I think that most patients want to talk about that. I find that more patients want to talk about that than their families. I find very often families are reluctant to talk about the reality of death more so than patients are. And if we all know that we're going to die, and it's a hard thing to talk about, but if we all know that we're going to die, don't we want to put as much thought and as much consideration into how we are going to die as we do in how we are going to live? That's why Holy Name has an inpatient hospice. That's why Holy Name is really promoting everyone having advanced directives. And I would say to any patient who says to me, no, doc, I want everything done. I want to be on a ventilator. I want every single opportunity to live every single breath I have. That's great. More power to you. That should be your right. But there are an awful lot of patients that I speak to who say to me, oh, doc, I wish someone had had that conversation with me because I don't want to die in an ICU. I'm 95 years old. I've had a really good life. I want to die in my own bed. I want to die with my family surrounding me in my own bed. I want to make sure I'm comfortable, which we can do, but I don't want to die in an ICU.
Right.
And
so, Dr. Jarrett, tell us if someone doesn't want to go through that incredibly invasive intubation. I mean, this is a hard question. Then what happens? How do you treat them? And how have they made those wishes known? Is that the advance directive? Is that a conversation with the nurse at the bedside? Or does it have to take place well in advance of them even arriving at the hospital?
I think the sooner you have this conversation, the better. I've had an advance directive and a healthcare proxy since I had children. My wife and I said, okay, we don't know what's going to happen to us. Let's make sure that we create healthcare proxies. In my situation, she is my healthcare proxy. I'm her healthcare proxy. We both discussed what our wishes would be, and we put that in writing. We know we're going to die. We don't think we're going to die tomorrow, but I could get in a car accident tomorrow and end up on a ventilator. And so I want the person that I trust the most, my wife, to know what my wishes are. So yes, I think those conversations should be had way before you get into the hospital. And if you don't have those conversations before you get in the hospital, you should at least have them with your nurse, with your doctor, with your pastor when you get into the hospital. And like I said, if you choose to have everything done, we can do that for you. But I've seen, unfortunately, an awful lot of people die. It's just the reality of being a healthcare worker for the past 30 years. I can tell you that the vast majority of people who die at home or who die in a hospice have a much more pleasant, a much more comfortable death than someone who dies in an ICU. And we have medication and we have other ways to make sure that people die comfortably at home. I lost both of my parents over the last several years. They both died at home. My mom died with home hospice. And she was extremely comfortable, and she was surrounded by her family. And it was on one hand, one of the most saddest things I've ever been through, but it only would have been worse if she was in a hospital. And my father,
go ahead. Oh, go ahead. I'm sorry, doctor. Go ahead.
And my father the same way. My father actually died of a subdural hematoma after a fall. And he had that conversation with me that he did not want to die in a hospital. And so he died surrounded at the Holy Name Hospice, actually, because it was better. He needed more acute care than my mom did, but he did not need to be in the hospital. And he was surrounded by his loved ones. And again, one of the most tragic things I've ever been through, but it would have been worse if he had died in a hospital.
Well, along the lines of what you've just been talking about, we have a question from one of our viewers. It says, I'm COVID positive and am self-quarantined at home, not sick enough to go to the hospital, so he says, or she says, but I wouldn't call my chest congestion minor. Is there any way to be seen and treated on an outpatient basis?
Yes. So all patients that have COVID-19 at home should be hooked up with their primary care doctor via telemedicine. We've done that with over 1,500 patients here at Holy Name Medical Center, where they're having at least once a day conversations and more if necessary. And patients who have significant symptoms are having monitoring at home. And you can do the vast majority of this monitoring remotely. We can follow someone's oxygen level remotely. We can follow their blood pressure and their pulse and their temperature. And if symptoms get worse, then we can bring them to the emergency room where they can be evaluated more carefully, not more carefully, but in a different way, in an in-place way, if we have concern that there's someone who needs more significant care. But the vast majority of coronavirus patients can be managed at home. They should be hooked up with their provider via telemedicine. They should have at least once a day, if not more, conversations with their provider, and they should be monitored carefully at home.
I have another question from a viewer. And I think this person is a healthcare professional. When do you and I wanted to circle back to some of the testing comments you made earlier in the program. When do you think an antibody test will be available to health professionals as well as the general public?
So at Holy Name, we're beginning antibody testing here today, actually, for the medical staff and the hospital employees, and we're very excited about that. We likely will make that available over the next several weeks to the general public. There is some issues as it relates to reagents and the chemicals that we need to do this testing, although we are being reassured that we will have more access to those reagents. As long as we do, in the next several weeks, we will make antibody testing available. But there is a caveat. We still do not know the exact meaning of an antibody test. So if you have we assume that if you have a high antibody level, that is better than having a low antibody level.
Could you explain to our viewers what exactly in practical terms, what is involved here with an antibody test?
So an antibody test is a simple blood test. It is not a swab. It is a blood test where we can actually measure the amount of antibody in your blood. There are essentially two different types of antibodies. It's a little more complicated than that, but there are two different types of antibodies. There's something called IgM, and there's something called IgG. IgM, immunoglobulin M, is elevated during the acute infection, and it does not give you immunity. IgG, immunoglobulin G, is elevated after the acute infection, and it does give you immunity. With different diseases, that immunity can be lifelong or it can be transient. And with different diseases, small amounts of that IgG can give you immunity. But in other diseases, you need to have large amounts of IgG to give you immunity. So unfortunately, the medical field is still figuring that out, which is why actually we're doing testing on our healthcare workers first. We're requiring our healthcare workers to fill out a survey. Did they have coronavirus? When were they diagnosed? What type of symptoms did they have? Were they treated in any specific way? And we're hoping that by using that questionnaire and comparing it to the antibody levels that our employees and our doctors have, and we're hopefully going to test well over 1,000 people in just our community, we can begin to draw conclusions about what a high antibody level means versus a low antibody level. We are optimistic that we'll be able to draw conclusions and be able to say to people, oh, you have a high antibody level. That's good. You're maybe someone who doesn't need to be as careful about social distancing versus someone who has no antibodies versus someone who has low antibody levels. And we're going to have to figure out whether those low antibodies are protective or not.
Wow. I think that this reminds me of some of the questions, social, ethical questions we had during the AIDS epidemic when people might have tested positive, but how do they tell the people around them, be it family, friends, et cetera? Do you have any advice on that? If you are tested positive, what do you do with your loved ones and maybe even your coworkers?
Yeah, so I'm a big believer in communication. I think you have to share with your loved ones, your coworkers, your community, what your antibody or your coronavirus status is. That's the only way we're going to protect ourselves. I think if we do that, and we have more information, we can begin to open up society in a much safer way than we can if we don't have that kind of communication. So that, I think it's key. You can't be ashamed if you've had coronavirus. In fact, if you've had coronavirus and you're doing well, you should be proud of it. You are much more likely to be immune. You are clearly did well because you're out there and you survived coronavirus, as the vast majority of people will do, and you are much more likely to be immune. So there's no reason to not talk about that. You should not assume you're immune yet, though, because we just don't understand it, and you need to follow the social distancing rules. But you should have a slight level of confidence that you're less likely to get reinfected and you're less likely to infect someone else.
Lindy, I know you had some other questions you wanted to ask.
Sure. I wanted to go back to some of the things that happen when a person is in the hospital or even after they've called an ambulance. And that is the decision about whether to have CPR. I know that sometimes that puts the people doing it at risk, and I'm wondering what kind of guidance you've been giving to your hospital-based staff about that, and whether patients can elect not to have that as well.
Sure. So CPR and intubation, being put on a breathing machine, often go hand in hand. Unfortunately, when a patient's heart stops or when their breathing stops, they often need both CPR and intubation. And CPR, like intubation, is a very traumatic experience. People say to me, well, I've seen people get CPR on television. It doesn't look so bad. The CPR they give on television is not adequate CPR, unfortunately. CPR is really a very difficult process that a patient would need to go through if necessary. It really means that someone, a healthcare worker, a doctor, a nurse, is pushing very hard on someone's chest and pushing through the chest wall, through the muscles in the chest, through to the heart to artificially pump the heart through that pressure. One very difficult reality of that is often when you give CPR, you actually break someone's ribs. And that's a very difficult thing to hear in terms of reality, but that's how traumatic giving CPR can be. To get adequate pressure to the heart, you can sometimes break someone's ribs. So getting CPR is very traumatic, and it should only be done. It should only be done if a patient has said they want that type of intervention, and if they understand what the benefit of that type of intervention is. If you give CPR to the right person in the right situation, is absolutely can be life-saving. But there are many situations where giving CPR doesn't really make sense. It doesn't really resolve the problem. I know we're not talking about this, but I will give you an analogy. Often getting CPR for metastatic cancer doesn't make sense. Many patients want it, and if they want it and their families want it, we of course provide that service. But giving CPR to someone with metastatic cancer, if you think about what the underlying problem is, which is the metastatic cancer, then giving CPR in many situations like that does not make sense, and it can be very traumatic. And that is why patients who have healthcare proxies, advanced directive, living wills, who've thought about this, often opt and say, when my time has come, and because all of our time is going to eventually come, I am going to choose to not have CPR, to not be put on a breathing machine. And if that is a patient's decision, it should be respected. It should be respected by the family members. It should be respected by the healthcare professionals. At Holy Name, we ask all patients who are admitted to the hospital if they want that type of intervention. We ask our medical staff to have those conversations as early as possible in someone's underlying care. And then if a patient chooses to not have CPR or not be intubated, we absolutely follow those wishes. And if a patient chooses to have CPR or intubation, we follow those wishes as well. And I know there are hospitals who've decided with coronavirus that they are going to not necessarily provide CPR for patients because of it does put our healthcare workers at increased risk. At Holy Name, we've decided that the patient's right to make that decision and the patient's family right to make that decision is crucial. And so if a family member or a patient who chooses to have CPR or intubation, we will provide that service. Even though sometimes we feel it may not be appropriate considering the patient's underlying condition, if the patient wants it, we will provide that service.
Doctor, along those lines, are you seeing any particular pattern on how people are actually dying? The way we understand it is that people die of complications from COVID-19, but the actual cause of death could be a heart attack or something else. Are you seeing any particular pattern in this? And also, if you could delineate that by ages, people who are in their 40s, say people in their 60s or 70s.
Sure. So the cause of death in most coronavirus patients is respiratory failure. So the lungs are just, even with the help of a ventilator, are just not able to get enough oxygen. And because you don't get enough oxygen, usually the heart will stop, or the heart will go into a life-threatening arrhythmia. Unfortunately, the unfortunate reality of coronavirus is if you are sick enough that that is a reality, that your lung are working so poorly that you're not getting enough oxygen to the rest of your body and to your heart. And the unfortunate reality is if you get that sick with coronavirus, then usually doing CPR is not going to help. And that's a very difficult conversation to have with families. But we have those conversations every day now. We try to have families understand that if your loved one is that sick, not that we're giving up. We are not giving up. We are still providing all possible care. But if they get to that point where the lung capacity gets so bad that the heart goes into a life-threatening arrhythmia or the heart stops, the likelihood of surviving and coming off that ventilator it's not zero, because there's no such thing as zero, but it's very, very close to zero. And that is why in many of these situations, we talk to families and we try to explain to families why not doing CPR may be the best decision for their loved one, which is a very, very difficult decision and a very, very difficult conversation to have.
Of course, yeah.
Many families understand that, and we have lots of patients here who are DNR, which means do not resuscitate. But families should also understand that we have patients here who are DNR who have survived, because the family has thought ahead and they've said, okay, I understand, Dr. Jarrett, if my loved one gets to that point where their heart stops, then we understand that nothing further can be done, and we want to have that DNR order in place. But we're not saying to withdraw care. And so we have lots of patients here who were made DNR because the families understood that if they got to that point, it would not make sense to do CPR. We've had many patients who were DNR who've recovered and have come off the ventilator and are doing fine because they were in good enough health, they got good enough care that they never got to the point where their heart stopped. But the unfortunate reality of this disease is if you get to that point where your heart stops, the likelihood of you coming off the ventilator is very, very low.
Doctor, we had a question from a viewer, slight change of subject here. This viewer asked, I've heard COVID is now being classified as a blood disorder. Is that true?
So I'm not sure I know what that means.
Yeah, I've never heard that. Not that I'm an expert on it. But
So coronavirus is a virus that is in most cases transmitted via droplets and aerosolization that you either breathe in or you touch, and then you touch your face or your mouth and you breathe it in. There is a blood test. The blood test that we use for coronavirus is the antibody test. There is not a blood test at this point to prove whether or not you have coronavirus. It's very difficult to isolate viruses from someone's blood. It's a very difficult thing to do. And so it is not a typical way that we test people for viruses. We do test for the antibodies in the virus, but we don't necessarily test for the virus in the blood. For HIV, which is absolutely a blood virus, we absolutely do test for the virus in the blood. I think for coronavirus, which is more of a respiratory illness, we probably will not do that.
Had another question here from a viewer. After things are reopened, and of course, you mentioned earlier that this might be in a series of stages, I think. But after things are reopened and this person says, I haven't had the virus, should I continue to stay separate from my family members who keep going out?
So I think that we need to listen to our healthcare professionals and our healthcare and public policy experts. Look, here's the very difficult reality. We hope to socially distance enough that we actually kill the virus off. The virus needs us as hosts. If we socially distance enough, the virus will die off, right? Because without us, the virus can't survive. And we hope to socially distance enough that we've killed the virus off. That's going to be very, very difficult. The amount of social distancing that we need to do to make that happen is probably beyond what we can do in all practicality. But there may be places where there has not been a big viral impact, where we have potentially killed the virus off in certain locations. I don't think that we're going to be able to do that across the board, however. And therefore, by socially distancing yourself, yes, you've protected yourself, and that's very important. But you've also protected your neighbors and allowed the healthcare system to have enough access so we can take care of those people who need it. When we go back to giving up on social distancing in stages, I do think you need to go back out. You need to do it in a very careful way. I wouldn't be surprised if the custom of shaking hands goes away in this country. That would not be a bad thing. Wow. I would be not surprised if we as a country don't do a lot better job in terms of washing our hands and not touching our faces. I wouldn't be surprised if we start doing a lot more meetings remotely and that we don't spend as much time in intimate contact with each other. I think that's the reality of the world that we're living in. It is unlikely that we're going to go back to life as it was 6 months ago. There are going to be things put in place. I think restaurants, especially in the beginning, I think tables will be spread out more. I think that there are going to be things that I haven't even thought of that are going to keep us safer in terms of some level of social distancing when this is over. But to think that we are going to prevent every single coronavirus infection going forward, it's just not realistic. And the good news is the vast majority of people who get coronavirus are going to do just fine. So if you're a high-risk person, if you're elderly, if you have underlying comorbidities, you are someone who probably will be social distanced longer than young, healthy people. And so as we do this in stages, it makes all the sense in the world for younger, healthier people to be out in the environment being exposed to people before the elderly and people with comorbid conditions are exposed to other people. So the person who called in, if you're a young, relatively healthy person, I think as we start reducing social distancing rules, I do think you need to go out in a careful way. If that person has significant comorbidities or is elderly, they should probably be on the tail end of when they start giving up on some of the social distancing rules.
Well, on that note, Doctor, we've kept you 10 minutes longer than our 30-minute program, and I appreciate you coming on with us. Did you have anything else you wanted to add?
No, I think the key thing is that we're going to get through this. Unfortunately, we're seeing an awful lot of people who are getting very seriously ill, and an awful lot of people throughout the country that have died, and that is just tragic. But I think people need to remember that the vast majority of people get well and are going to do fine. And at some point in the hopefully not too distant future, we'll talk about coronavirus and we'll remember what it was like and hopefully be able to move past it.
Well, thank you very much. Thanks, everyone, for joining us today for Ask the Expert live on NorthJersey.com with Dr. Adam Jarrett. And for my colleague, Lindy Washburn, I'm Mike Kelly. Thank you.